We're now going to talk a little bit about platelet disorders. The most common one that you're going to get on the exam is ITP, or immune thrombocytopenic purpura. It's also the most common that we see in real life. What happens is there's some kind of a trigger and you have an autoimmune response against the platelets themselves, so that your body starts attacking its own platelets. Typically look for a prior viral illness. The patient is now recovering from this viral illness and looks well, except for the parents will say it's a rash. Well, it's not a rash, it's petechia and purpuric lesions. It's very important to have that history, and on the physical exam you see those lesions, but you also see that the patient is otherwise well. That's a really important clue. If the patient has an enlarged liver or spleen with this, that is not ITP. You should start thinking of some other disease that's causing these problems. The majority of ITP resolves on its own. It takes sometimes a few months, but it'll go away on its own. There is less than a 1% mortality rate, and usually it's secondary to an intracranial hemorrhage. 10 to 20% of patients will go on to develop chronic ITP. Usually the platelet count is markedly depressed, less than 20,000, but the platelets themselves will be normal in size, or sometimes a little bit increased in size. Remember, this is destruction that's occurring in the bloodstream. So if you do a bone marrow, you will notice that there are normal precursors. The megakaryocytes will be normal. The platelets themselves in the periphery are normal, they're just being destroyed. You rarely need to do a bone marrow aspiration, but that will give you the definitive diagnosis, and a bone marrow aspiration should be done before you start steroid treatment to rule out other diseases, particularly leukemia. Most patients do not require platelet transfusions, and so we try to avoid them if at all possible. Some patients will respond to immune globulin, IV immune globulin. Again, remember, if you receive IV immune globulin, you should not be getting an immunization a live immunization for at least 3 months. You can go ahead and start steroids. Those patients will need a bone marrow first to make sure you're not hiding a malignancy. And some patients with chronic ITP progress to have a splenectomy. These are patients that have not responded to medical management. Chronic ITP should make you think of this differential diagnosis, such as an autoimmune disease. Also remember Wiskott-Aldrich. Remember when we did the mnemonic for Wiskott-Aldrich, we said Mr. Text, and one of the T's is thrombocytopenia. Of course, with Wiskott-Aldrich, you're going to also see other findings. Von Willebrand's can course with thrombocytopenia. Kasabach-Merritt, that's one that is a large hemangioma, and the platelets are trapped there. So if you're reading a test question and they want you to think about Kasabach-Merritt syndrome, they will describe the findings of a large cavernous hemangioma, and the platelets are being trapped there. Malignancy should always be in your differential diagnosis of immune thrombocytopenic purpura, because particularly leukemias, as there's bone marrow infiltration, the platelet number will also decrease. And that's why if you're going to start steroids, you should do a bone marrow aspiration. There's also something called TAR, which is thrombocytopenia absent radius syndrome. And these patients will have an absent radius, a low platelet count, and with the absent radius, the wrist tends to move in more, and you can actually see the deformity of the hand at the wrist, and that's easy to spot. An X-ray shows an absent radius, and remember, gross abnormalities of the upper extremities, think of any associated cardiac problems.